I think we are going to start because we are a little bit late. I hope all of you are enjoying the European Digital Health Summit, and you enjoyed yesterday the first day of our summit, in which we have the opportunity to have with us some politicians, also Marco Marsella from the European Commission, and the outstanding keynote speaker, Escobajo. Yesterday, we were more focused on strategic level policy and big ideas, let's say. And today, we need to materialize what we were starting to think of the brainstorming that we did today. Now we need to start thinking on how we do in Europe an action plan to make it happen, how we implement policies to make this a reality. But let me remind a little bit what we did yesterday. First, I think in the session on AI, we discovered that AI and data can transform healthcare. Only if we ensure trusted access to high quality, sorry, I do not see very well now, data set, protect citizen rights, and redesign workflows in a way that healthcare can be implemented. So healthcare should be at the heart of the AI strategy. We need to facilitate market access to do pilots and to implement many different solutions of AI in the healthcare sector. So second, we also were hearing yesterday a lot about the resilience and cybersecurity and how it is important to have cybersecurity in the health sector at local, regional, national, and European level, and how it has to be coordinated in a way that ensure we are a more resilient health continent, let's say, or region. Then, and as a third insight from yesterday, I would say that in the industry dialogue, we also heard that cybersecurity, funding models, skills, and digital skills are not really side topic, are still key for Europe. So they are the foundations to make patients and more satisfied, to make regions work better, and to offer better services for all. So I want to thank to all of the moderators and speakers yesterday to really the high performance that they did. And I want to also thank you, the speakers and the people that has been contributing to the European Digital Health Summit. And today, we have an agenda in which we will go into action. The Master of Ceremonies for this room will be Madalena Hilario, and we have another room because today we are working in parallel session. And the Master of Ceremony will be Anderson Carmo. Then the agenda for today really will be in the morning, we will have a number of parallel sessions. Then we will have a light lunch, and after that we will have the Latin American chapter. So I want to pass the floor to Madalena and enjoy the day and all the parallel sessions. Thank you.
So, good morning, everybody. I'm pleased to be the Master of Ceremony today, and welcome to the session A1 on European Electronic Health Record Exchange format. Before we continue, just a brief practical note. This meeting is being recorded and photographed, as indicated in the privacy notice included in the registration process. By attending, you consent to being part of the summit's visual materials. I hope you will stay after this note. And the organization will use selected excerpts to prepare short highlights videos capturing the key messages of the summit, as well as the general report that will be published and disseminated in upcoming weeks. If you share
first session in this room that will be the session about medicines procurement as a driver of access. So before we continue, a brief practical note. This meeting is being recorded and photographed, as indicated in the privacy notice included in the registration process. By attending, you consent to being part of the summit's visuals materials. The organization will prepare a short highlight videos capturing the key messages of the summit, as well as the general report that will be published and disseminated in the coming weeks. So, if you share moments in social media, we invite you to use our official hashtag EHGS25. Now, to begin, the procurement policies play a decisive role in ensuring timely access to the medicines and driving innovation in healthcare. With the upcoming Critical Medicines Act, member states and EU institutions face the challenge of aligning procurement practice with resilience, affordability, and sustainability goals. So, for this point, we have our moderator for this session, Liv Lewis, international lead of Bevan Commission, and panelists Patrizio Armeni, Anna Maksimainen, David Hawkins, and Victoria Vols. So, Liv is an expert in healthcare policy and systems transformation, over 20 years of experience in strategic health innovation and value-based procurement across UK, EU, and international settings. She has supported several European initiatives focusing on sustainable procurement and in the integration of digital solutions in healthcare delivery. So thank you, Leo, and the speakers. I would like to invite you to come to the stage and have a great session. Thank you so much.
Thank you, Anderson. And it's my job to introduce our speakers, who will bring really important perspectives to this topic of conversation in the summit today. First of all, Professor Patrizio Armeni. He's Associate Professor of Practice at SDA Bocconi and coordinator of the Digital Transformation Hub at CERGAS SDA Bocconi, sharing his research insights on value-based procurement and economic resilience in healthcare. Patrizio is one of Europe's leading researchers on value-based healthcare and health economics. His studies explore how economic evaluation can drive resilience and sustainability in health systems, and he coordinates the Digital Transformation Hub, which is a multidisciplinary research pool where digital health is explored from a variety of perspectives, for example, policy, management, technology, markets, etc. He is also a frequent advisor to public... Now I'm being exposed as being vertically challenged, but that's fine. He's also a frequent advisor to the public authorities on aligning investment strategies with digital health priorities. So welcome, Patrizio.
Thank you. Thank you for the
Anna
invitation.
Maksimainen is the Vice President and Senior Partner at Nordic Healthcare Group. And Anna leads public sector projects on health and social care reform, digitalisation and value-based procurement across the Nordic region. With a background in consultancy and digital transformation, she supports governments and healthcare organisations in building more sustainable and data-driven systems. David Hawkins is project leader at the National Digital Health and Care Innovation Centre, AIM for All. You will see his title on the slide is actually incorrect. So just make sure that you don't think that he's Nordic Healthcare as well. David has extensive experience leading national digital transformation and innovation programs, connecting procurement policy with data-driven decision-making. His work focuses on leveraging digital tools to optimize care pathways and improve access to essential medicines within integrated health systems. And finally, Victoria Vols. She's Health Innovation Manager at Aquas. Victoria is an innovation project manager specialising in public procurement of innovation and value-based adoption of digital health technologies. She's led initiatives such as the Health AI programme and Radar PPI project. In this session, she will share Catalonia's experience in the procurement of AI algorithms to drive innovation and healthcare. So please join me in welcoming our speakers on. So let's have a think. Some of you may wonder what the Bevan Commission is, so I'll just explain that the Bevan Commission is Wales's independent health and care think tank, and I'm the international lead of the organisation. And I have to say, I'm absolutely delighted that today's event is in the Palace, because within my family, I am the Queen. Haven't got my crown on today, but I'm known as the Queen, but my husband is not known as the King. So maybe that says something about who wears the trousers in our house. So, in this session, we're going to focus on one of the most strategic, yet often underestimated levers for health system resilience, and that's procurement. Jose, in his introduction, referred to the cybersecurity that we covered in a lot of sessions yesterday. But procurement always sort of seems to be the Cinderella of when we look at health systems. It's the people over there that do it. So whilst we're going to be focusing today on medicines procurement, it's important to remember that procurement policies more broadly, including for medical devices, innovative technologies, also ways to deliver different care processes can also be procured. They all share the same mission: ensuring timely, equitable and sustainable access to what patients and health systems need most. And at this point, I'm just going to share with you the prudent health and care principles that Wales' health and care system is predicated on. The first one is co-production. We need to achieve health and well-being with the public, patients and professionals as equal partners through that co-production process. The second one is necessity. And this one's really, really important. Do only what's needed. No more, no less, and do no harm. I think we're often seduced by, and we were hearing lots on AI stuff yesterday, and sometimes the new advances are not relevant for somebody's needs, but often the system will put them through having unnecessary tests and investigations, for example. The third principle is need. Care for those with greatest need first, making the most efficient use of all the skills and resources, the equity issue. And then finally, evidence. Reduce inappropriate variation through using the evidence-based practices consistently and transparently. So with the up-and-coming Critical Medicines Act, Europe is taking a decisive step to strengthen the security of supply whilst keeping affordability, innovation and resilience at its core. Our discussion is going to explore how procurement can move beyond the lowest price approach that I think we're all familiar with, not just with medicines but with everything else, to one that values reliability, quality, long-term sustainability and outcomes for people, stabilising supply chains and rewarding responsible innovation. We'll also reflect on how national authorities, industry and healthcare providers can embed value-based and resilience criteria into tendering processes, aligning efficiency with public health and innovation goals, and ultimately create a procurement ecosystem that supports not only the markets but people, securing access, driving innovation and ensuring preparedness for the future. So with that, we'll start our questions and we'll do it in 2 rounds. I'm going to ask each of our panelists to give a perspective on a question that's for their expertise, and then we'll move into more of a panel discussion on a series of questions. So first of all, Patrizio, how can value-based procurement principles be applied to medicines purchasing to balance affordability, innovation and sustainability while ensuring long-term efficiency for health and care systems?
Well, thank you for the question, Leo. And I think that when we talk about medicines, it's important to divide between new medicines and mature medicines, so off-patent drugs. For new medicines, what is really important is to have an efficient health technology assessment, because it is where you define the conditions, both economic, clinical, organizational conditions, that allow these medicines to have an equitable access through the country. And in the case of new medicines, procurement plays the role of ensuring contracts that match what has been found in health technology assessment to secure these medicines access to the country. But when we talk about mature medicines, and please be aware that these are in Europe around 2/3 of the total volumes of medicines, even though they only represent 10% of the expenditure. So maybe just looking at the expenditure, it's the reason why so often procurement is considered, as you said, the Cinderella of the situation. But there is where procurement becomes a strategic asset, but also a potential lever for a total disaster. Why? Because according to the way these medicines are procured, and value plays out very differently compared to new medicines, you can ensure a competitive, sustainable, equitable market, or you have a new monopoly, but with a difference. Because when you have monopolies, in the case of new medicines, this is a legal monopoly. When there is a company owning rights on a drug, they sell it for a period of time, then it allows them to be generic. But with mature medicines, if you are not able to create a competitive market, like for example, just looking at the always lowest price, so you do tender after tender and you always lower the price, and because you say, oh, maybe I've received one offer, and then, so this price is sustainable, gradually, what the data show us in Europe is that the market has been gradually deserted. And we have, for 15 years ago, for some medicines, we had some 15 companies offering to tenders. And now in some countries, we have 2, in some cases 1. And we have a lot of desert lots in tenders. This means that we have underestimated the importance of strategic procurement, because we think that value for mature medicines is always taking and looking for the lowest possible price. This is not the case. What we expect from a good strategic procurement action is not only to have a reasonable price, which is right in the case of, let's say, old medicines, but they are critical, and maybe we can get back on that later on. We expect not only to have low prices, but we expect to have affordable, sustained supplies over time. We need not to depend on foreign countries or too far countries for critical supplies, like, for example, antibiotic or anesthetics. In some cases, we only have anesthetics produced in the Far East, like China or India. It's not just a matter of quality, it's also a matter of dependency. So do we have the internal capacity in Europe to sustain this such critical market for medicines or not? If we always go for the lowest possible price, we don't. We don't have this possibility, and we will lose gradually the potential of having a reliable market in Europe. So these are just the first thoughts on this.
Great, thanks, Patrizio. And now, Anna, drawing from your work on innovation procurement in health and social care, how can these approaches inspire more effective and outcome-driven procurement models for medicines and other health technologies across Europe?
Thank you for the question. If a little bit going backwards to explaining like what kind of work we have also been doing within Nordic Healthcare Group. So Nordic Healthcare Group, to friends, NHG, is a originally Finnish company, advisory insights and research company that was founded 2004 as a spin-off from a university. We have been working in many thousands of projects developing health and social care with public and private sector operators. For the past 10 years, we have been focusing on how we can create more value-based system, how we can bring next to the outputs, when you're measuring just outputs, processes and deliverables, also to focus more on the value that is being achieved from the service provision. And we have been helping the clients not only creating the vision and strategy to transform their operations towards more value-based healthcare, but also been implementing the principles of value-based healthcare in practice. We have been applying these principles not only in secondary care, for example, psychiatric care. We have been implementing value-based segmentation models. In primary care, in social care as well, we have been doing value-based procurements in child welfare protection, in elderly care, home care services, also abuse, drug abuse and alcohol abuse services, as well as employment services. So these value-based principles apply in all the wide-scale spectrum of health and social care areas. And as we have in Finland, integrated health and social care systems, so that's why I bring always the social care next to the healthcare. When it comes to value-based healthcare, that is actually a very valuable tool in transforming the equally shared inclusion that we are all the provider, procurer, and also the end user is being all included to work towards the shared goals that are being defined jointly for the overall production or the service in hand. And this enables also for medicines and other medical technologies also to transform how we have used the way we provide services or well-being to the people. So it can have a huge impact in overall operations that we are doing at the moment.
Thank you, Anna. Now on to David. How can digital platforms and real-time analytics support more transparent and efficient procurement, helping decision makers anticipate shortages, manage suppliers, and drive better health outcomes? No pressure.
Well, lots of questions there, and thank you, Leo. And it's a pleasure to be here. I represent two organisations. I'm a co-founder of the Access to Innovative Medicines for All initiative, or the Aim for All initiative, and also the founder of an innovative financing business called Remedium Capital. I'm a bit of an imposter in this room because I'm a banker by training, and my fellow panelists have much more expertise in this area than I do. I sit in the uncomfortable intersection of data that just isn't good enough, procurement, contracting methodologies that are decades out of date, and patients that are desperately ill that want access to the most innovative medicines. That's where I sit. And the title of today's talk, Medicines Procurement as a Driver of Access, getting the right products to the right patients at the right time in the right condition for the best possible value. I'd like to be sort of slightly provocative and say that in many instances, particularly in the case of innovative medicines, medicines procurement is actually a barrier to access. And it's a barrier to access I see for two reasons, two principal reasons. One is that medicines expenditure is seen as a cost rather than an investment that can be measured, shared, and underwritten. And secondly, we have a sort of a procurement culture where the default position is our preference is for a simple discount. And that, let's not be kidding, that mindset is not neutral. I think it actively undermines the access that patients have to innovation. If you like, it's a 20th century reflex to a 21st century problem. and a problem that's actually an industrial scale challenge that is not going to go away as far as innovative medicine is concerned. And unless we tackle that, and unless manufacturers can see a clear path to acceptable launch pricing, we have an unattractive environment in which to do sort of clinical trials. And post-approval, we face delays in the access of novel medicines, if indeed we get access to those medicines at all. And so the work I do, which is on two fronts, through the Aim for All initiative, we're trying to break down those barriers. And we're seeking to break down those barriers by sort of creating an environment in which failure is acceptable. If you like, a learn by doing, living lab environment in which we expect to fail in some instances, but we have a remit to be very innovative in terms of how we look at market access, new products. This work has been centred in the Digital Health and Care Innovation Centre in Scotland, and since we've started, NHS Wales have now come on board, as well as the Advanced Therapy Treatment Centre network, which is a pan-UK network of hospitals that is focused specifically on ATMPs. And what are we doing in that work? First of all, we've demonstrated that actually we can align all of these stakeholders. It is possible to get all stakeholders aligned. We've done work in the field of CAR T-cell therapy where we've demonstrated it is possible to agree a standardized data set that meets the needs of all stakeholders, not just sort of practicing clinicians or meeting the needs of outcomes-based contracting. Thirdly, we've demonstrated that it's actually possible to generate that data as part of routine clinical practice, so in a way that doesn't place an additional burden on clinicians, but is seen as a benefit to clinicians because they see collecting that data. First of all, it's digitalized, but they see the benefit of collecting that data as improving the dialogue they have with their patients. So we've demonstrated we can collect that data, and incidentally, without a wholesale change of IT infrastructure, which is fundamental. And we've also demonstrated that by sort of creating data governance playbooks and service models, that thinking can be applied in other jurisdictions, and Wales and the Advanced Therapy Treatment Centre network are a good example of that. But good quality data and innovative outcomes-based contracting still don't necessarily lead to access. And the reason for that is you still have to achieve pricing that sits within the pricing corridors of manufacturers at launch. And there is an increasing pressure now from, given the US pricing environment to achieve higher launch pricing in smaller markets in Europe than was otherwise the case. No manufacturer who typically generates 80% of their earnings from the US is going to risk those earnings being cannibalized by accepting lower launch pricing in smaller markets in Europe. And so we need an environment in which we can generate high quality data. We can we have a means of a culture that's open to innovative outcomes-based contracting, but also can deliver attractive pricing at launch. And that last piece is the challenging piece, because higher launch pricing means health systems have to take more risk. But do they? And that's exactly the work that we've been doing through Remedium, through innovative financing. And it is possible to achieve a win-win-win, where health systems can deliver those prices without taking risk, where manufacturers can achieve the higher launch pricing that doesn't cannibalize their US earnings. And in doing so, we can achieve access to the most innovative medicines for patients. So that's some of the work that we've been doing in the background as I see it, and in the coming months we're taking all of that work into a live environment over a number of use cases, and we have interactions across Europe, the Middle East, and North America in terms of that, so those methodologies. Hopefully that's helpful.
Thank you, David.
Thank you.
Thank you. And now on to Vicky. So based on Catalonia's experience with procurement of AI algorithms, we heard lots about AI yesterday for those of you that weren't here, and value-based innovation, what lessons can be drawn for designing tenders that reward quality, results, and long-term value rather than solely focusing on cost?
Thank you, Leo, for the question. So first of all, I want to introduce, because the AI procurement in Catalonia came, so artificial intelligence program was created in 2023 by the Catalan government with the aim to generate, implement and adopt this technology in the healthcare system. So, but at the end, the final aim would be improve the quality of care, the sustainability of the system, also add value to the knowledge generated, but always it has been based on the need. So the need that was established or prioritized by the health system were the challenge selected, and that has been procured at the beginning. So after 2 years, there is already a challenge that is being implemented, the diabetic retinopathy, and there are 4, 5 that are being in the process to being awarded. So during this process, we have learned a lot, and we will learn more. But I think that until now, what we can say is that, first of all, it's very important to involve everyone in the detection of the needs. So that means from patients and citizens, but also healthcare professionals, the healthcare managers, the managers from the healthcare system as well, and at a socioeconomic level. Because at the end, when you detect the need, you have the pains from everyone, then you are ready to really look for the solutions that may be helpful. And with that, understand the value that this implementation will have for everyone. So, and as well, it is also helpful for the change management. At the end here, it's a regional program, right? So we are implementing in all the regions. So in the equity part, the final aim is that in every place you live, you will have access to those technologies. So on that sense, we have to keep this in mind, and knowing that the change management in all the region, it's a plus challenge of being only in one place. But I also think that when we look for the results we want to obtain, have to be aligned with the results that each stakeholder level are willing to really achieve. And also with the market, because at the end, obviously, a market, the different companies, so it's very important really to have a dialogue on the open market consultation and really learn in which stage, which maturity we are or they are for the technological part, but not only for the technological part. There are a lot of other aspects that will lead to the adoption of the different technologies. So I think that with that, if we move to more for the tender on how we prepare the tender, after understanding the value that it had for everyone, what we did and we analyzed was the risk we had to really not being able or being able to achieve those results. So we also realized that when we are aiming to provide value and to everyone, sometimes we find that there is not already evidence generated. So we should generate that evidence in a way to de-risk the procurement. So that's another point, that during the procurement, we are generated evidence in our system that will help us to make a decision in the future, obviously, but also to understand better how the solution is functioning in our system. And then to really keep that, I think it's important to obviously, on the call for tender, but also that in the bid template, so every tenderer So the tenderers should be ready to really respond and give value, like participating actively, because at the end we are collaborating, right? So they should be part, the tenders, we should share the value that it has for us, but the bidders should be also there. And there are two particularities that I think that that has been important as well are, on one side, we have included during the tender process quality test validation, because at the end, we know that the solutions are certified, but in every system there are differences in the population that may vary the results, the metrics we obtain. So we, depending on the needs, or I would say the time we had, we included during the process or during the contract. But I think that's also a good manner, and that's something that the professionals asked us, like, we are procuring solutions, but we know that they are certified, but how they are working with our population. And the other issue or that thing that it was good to tackle, I would say, or that we tackle, obviously, here it's the MDR and also the Artificial Intelligence Act, that, well, it's coming, it's not new, but it will be, well, it will evolve during this year, so that's something that we also have been tackling during these procurements.
Thank you, Vicky. So, those of us that were here yesterday, all those challenges and critical success factors that the panellists have referred to, we were hearing yesterday, weren't we? So why are our health and care systems operating in these sort of process silos? We could be getting much more traction if we started to work across the departments and staffing groups in order to, really make a difference. So with that in mind, we're now going to do a sort of a deeper dive into some of the challenges and critical success factors that they've touched on in their initial responses. And we're going to do it in rounds. We're not going to go to everybody for every question, because we're trying to play to each of our panellists' expertise. I'm somebody that doesn't believe that anybody is an expert. I think we all have expertise, and we've got lots more learning to gain from listening to what others say. So I will never refer to somebody as an expert. But Patrizio, you first. We're going to pick up on Vicky's last point on the Critical Medicines Act and think about how member states can align procurement frameworks with the new Act to strengthen supply resilience and affordability.
Yeah, thank you. I think it's a very central question, but let me take one step behind. So why the Critical Medicines Act? The reason why we need such an act is because access to innovation throughout Europe is uneven. And second, because looking at mature drugs, we are losing competitiveness and we are losing companies supplying them. And we increase the dependency as Europe from other parts of the world. And in times of crisis and international tensions, we can't accept not being self-sufficient on critical medicines. So that's why we need such an act. And so what's the reason why we need it? Because if we want to achieve self-sufficiency, we have to lower our dependency from abroad. But why are we so dependent from abroad now? Because drugs are cheaper in some cases. And it's important to say that if we want industrial production in Europe of critical medicines, this comes with a cost, and it's not for free. But it has a lot of pros. And what are the pros? Less shortages, more resilient supply chains, and of course, a greater shared responsibility. Because when you have plants in a country, when you have workers in a country, your degree of partnership with the total economic system grows. If you are just an import-export, of course your presence is somehow, let's say, spot, and can be changed in a very long term, in a very short term. While when you have plants, when you have workers, when you have long-term contracts, this also creates a barrier to exit, but also a shared responsibility within the companies and the government. But what is the enemy of all these? Tenders chasing the lowest possible price. And also, as you said, David, the preference for having discounts rather than creating complex contracts. So contracts can be complex, but we have all the means to do so. We need to fight, for example, hyper-bureaucracy on some of these contracts. For example, in some countries, we have observed a decrease in the use of managed entry agreements just because of their bureaucratic burden rather than their efficacy, because they were very effective in sharing the risks. The problem is that you can't have such a contract, for example, in Spain, not having it in France or in Italy or in Germany, because from the company's perspective, this creates, this jeopardizes the efforts and does not create a consistent solution. It's very important that member states coordinate on several issues. For example, standardizing the way we define value and include this definition of value into tenders. So it's not acceptable that one country rewards price, the other countries reward resilience of the supply chain, the other countries takes into account also where the medicines are manufactured. We need to agree on the fact that if we want a European industry producing, let's say, and giving birth to a reliable supply chain, we need to have a European-wide effort on this. So we need that to agree that all countries do not just do tenders at the lowest possible price, but also incorporate other elements of value. Because when I look for critical medicines, I'm not looking at just cheap medicine. I need those medicines as the priority number one. Priority number two is that they are affordable. It's not the opposite, because if I switch the two priorities, I won't have these medicines anymore, because companies are rational players and they prefer working in markets with higher rewards or switching their portfolio medicines with higher rewards. For example, I said that innovation is uneven in terms of access in Europe, but it's easier to access innovation compared to sustain critical medicines that are not necessarily new on the market. So that's why we need to incorporate these elements of value. But the effort should be shared, because if we take two different perspectives across Europe, then companies will adopt, let's say, an opportunistic view and start selling more in some markets and will exit other markets, and these markets will depend on other foreign suppliers, and when we have a crisis, the markets that rewarded should help the ones that didn't, and so this will, let's say, waste the effort they did. So that's why we need a sort of consistent and European-wide strategy.
Very good.
Thank you.
Very good, thank you. The second question, I'm going to start by asking David to give a response to, please. And you touched on it, Patrizio, in your answering question one. So procurement teams are often accused of being risk averse. Is that fair? And could it be because some argue that innovative contracting is too complex, just as Patrizio was saying?
I think it's entirely fair, but at the same time it's understandable. Understandable not because of complexity, which I think is sometimes used as a convenient excuse, but because we have a procurement culture that punishes failure and doesn't reward innovative thinking. In terms of the sort of the complexity piece, hey, I'm from the banking world, and I've seen the intellect that's required to bring a new medicine to market, and it is way ahead of anything that's required in the banking world. Yet the banking world can underwrite $1 trillion credit market, and yet health systems can't underwrite a CAR T therapy. So I think it's not complicated. I think it's just some of these sort of new approaches are just not familiar. And one of the things that we saw at the time of the pandemic was health systems actually reaching out to external expertise that wouldn't necessarily be brought into the room. And so I think, you know, this is one area in terms of the sort of innovative financing and underwriting risk. And Patrizio, you know, when it comes to sort of bringing manufacturing to Europe, take the UK. A major manufacturer generates 80% of its income from the US and possibly 1.5% of its income from the UK. What leverage does the UK have over that manufacturer unless the UK is prepared to offer that manufacturer attractive launch pricing, and the manufacturer during the development process can actually see a path to that? Now, if manufacturers see a path to attractive launch pricing in Europe, and that can be achieved through something that's regarded as complicated, it can be achieved, then suddenly you have leverage in terms of bringing manufacturing and bringing greater resilience in manufacturing and supply to Europe. So fair but understandable and complex only because some of these things are not familiar, not because they're actually complicated.
And also the health and care in most of our regions is made up of a lot of what are perceived to be autonomous organisations, yes, but actually organisations whose, I won't say mandate, but remit is to meet a person's needs.
Yeah.
Yes. And so it's.
And Leah, you mentioned, you know, sort of silos, and you know, this is one of the big challenges we face. You know, heavily siloed personnel that have very well-defined mandates, and when you try to bring about change, you're faced with these sort of system forces. You have a system that's working like this, and you're trying to make it do this, think differently, and you can't do that unless you have individuals within that system that have a clear mandate for blue sky thinking, and are connected with all of the stakeholders in the system and can actually bring those stakeholders together. And that's what we've been very successful in achieving with the digital health and care. Oh, completely different. Completely different. And it's nobody's fault.
What they've been trained to do.
Yep.
And not everybody can be a good networker or think differently. And we need to find ways to actually identify our change champions.
It's nobody's fault. You know, it's just the system forces that only somebody connected but outside the system can challenge.
Yeah. So Vicky, in your experience, is what David has said, does it resonate with?
Yeah, I mean, I agree with him. I think that it's fair, but I mean, it's understandable. So I think people in general, so we are more confident doing things that we have done before, and we have done I mean, there are much more procurement than innovation procurement, so it's much easier, I would say, for them. But this is the reason I think that it makes sense, and we really need communities and upskilling programs for professionals. And when we talk about procurement teams, at least in our experience, or I would like to say that it's not only the legal team. We like to include innovation managers, but also innovation project managers, the healthcare professionals, IT. I mean, everyone. Obviously, everyone has its own role. The legal has a key role, because without them, I mean, they know what we can do, what we cannot do, and as an innovation project manager, I would say that I cannot do a procurement without them. But I also think that the combination of, as you have mentioned now, that the combination of everyone there, it makes innovation to come and do things differently. And obviously, it may be more complicated. And in our experience, for example, with the EI, have been, it would be probably easy buying by price. But yes, what we want really here is see the value of what we are buying really. And if it's maybe more complicated, I think it's worth, because what we want to achieve at the end, it's not what we have now, currently at the December, sorry, it's what we have in 5 years, really, if our patients can use, if the professionals are happy with the solutions we are buying, and if the system is sustainable, of course, and also when we come to ecosystems as well, because we need an active ecosystem that it's trained as well to respond to those challenges, because if not, it's not only, as I said, the public, the public sector, it's all that we need to be trained and learn and from each other. So I think that yeah.
I think Anna wants to sort of enhance,
Yes,
elaborate on one of your points, Vicky.
Yes, we made a query for the well-being counties who are responsible for organizing services in Finland last year about value-based procurement, and are they planning to are they planning any value-based procurements? And the most replies were quite depressing, that no, they are not, due to the financial restraints that the Finnish public sector is at the moment. They are very much forced to just like take the next procurement and get the prices down immediately, because we have a huge cost cut-down pressure for the next 2 years. But what also David said, that the demand should come from wider up, because at the moment the government is pushing just like cost cuts, and they are not pushing value. They are not pushing the system to provide value. They are only pushing the system, the whole health and social care system in Finland, to provide cost savings, and that is showing all around Finland at the moment. So it's the demand, it has to come from wider up, whether it's a national government or it's European authorities providing either regulatory frameworks or creating demand.
Yeah, and that sort of tension is also relevant for, you know, the governments are wanting the cost cutting. They see that being resolved with increasing productivity, cost cutting, but the value bit is nowhere to be seen, which is not where our heads are at. You know, it's starting from the wrong position, isn't it? So Patrizio, just short comment to conclude.
I also can share the Italian perspective on this. And just to answer your question, yes, I do think it's true. It's fair to define these procurement offices sometimes as risk averse. And I also think it's understandable, because it depends on the kind of culture and incentives that they have for their own behavior. And in Italy, we have the particular situation where we have a lot of people that have done this job for, 30 years now, and have become the bosses of the teams managing the operational procurement. And their mindset is always the old one, looking for the lowest possible price. Not even, I would say, 20th century, but maybe the last 2 decades of the century. Okay, it's not something new. It's the 1800s that we have this kind of mindset. My point of view here is that we not only need to let them experiment, but we need these experiments not to stay at the local level. Because we have interesting experiments. So, for example, we have a couple of regions in Italy that have tried the value-based contracts with risk-sharing agreements incorporated, but they are only for a population of 400,000 people. Mm-hmm. And Europe is 400,000 million people. Mm-hmm. So that's the difference. Mm-hmm. So in the perspective of a company, it's interesting to have there for those people a risk-sharing agreement, but it's not a real risk-sharing. And also it's a matter of framing. If officers think that, for example, risk-sharing agreements are a way to punish failure, the way of framing is always to, let's say, fight a battle between the public sector procuring medicines or medical devices and companies, the evil of the market that wants profit. And this mindset does not help in creating partnership and does not really share the risk. Yeah. You want to punish failure. It's not sharing the risk. A good perspective on risk sharing is explaining those officers that it's a way of trying to have access, not a way to punish failure. Maybe the contract stays the same, but the mindset with which you manage it and the way you interact with companies that has an impact in attracting those companies on your market changes a lot.
Yeah, I think, again, the risk-sharing agreements, data-sharing agreements, the approach has been exactly the same. Specify it for this small cohort instead of looking at its application across
or at least coordinated, consistent one with the other.
Yes. Thank you. So looking at data and analytics and digital tools, which we heard lots about yesterday, let's have a think about how these might help transparency, help monitor supplier performance and long-term outcomes. We'll start with David again.
Yeah, absolutely. And just sort of picking up on that, I mean, sort of presupposing an environment where actually we have a model of 21st century innovation partnership between health systems and manufacturers, which I think is the bedrock of all of this thinking. I think to answer your question, I think it's all about standardization, common data governance and service models, standardization of data sets, digitalization of treatment pathways, and collecting data as part of routine clinical practice, which can be done in a way that's beneficial and not an additional burden on clinicians. And one thing we've not spoken about today is actually, and if we're going to justify higher pricing, you need to capture the complete patient journey. And we live in what's crazy. We live in a world where citizens have never been more tech savvy. So it ought to be possible to do that, not just sort of patient PROMS data, but sort of carer-generated data and so on. That's really important if we're going to justify investment in medicines as a result, other than costs of medicines. I think the other point, we hear a lot about sort of AI models spending enormous amounts of time on swathes of historical data, and I think we need to stand back a little bit and actually start thinking about focusing on some of the big questions that are being asked. And as I see it, there are two questions that are being answered: pre-launch and post-launch of products. Pre-launch, it's all about identification of patients. Manufacturers are committing significant amounts of money to development budgets without really understanding how big the patient population is, because that data is simply not available. So, one of the things we need to be able to size markets more effectively. That can improve the efficiency of drug development. And post-launch, it's about using products in an optimal way to get the best possible benefit out of those products, which is, again, fundamental. I think the other piece is around tracking patients, and pre-launch, that's all about an environment in which it's possible to undertake sort of comparator studies in live. And post-launch, it's all about measuring outcomes. So think about those sort of big questions: identifying patients and tracking patients pre-launch and post-launch.
15 minutes, okay? So if we can just keep the answers a little shorter. I'm going to come to Anna next, and then you, Vicky, okay? Anna?
Yes, regarding the use of data, maybe I would just highlight the perspective that it enables us to track the performance of the suppliers much more better than we have until now. The data that we have been piloting or implementing different value-based practices, it's, even though in Finland we have data, it's not there ready for this kind of applications. So you have to pretty much build from the scratch up the database, also the applied metrics. Okay, you have ICHOM metrics, for example, ready-made that you can implement in the case that they suit for, but then you have to build all the dashboards and reports to be able to monitor, to follow up the performance of the suppliers. It only does not provide the way to follow up the costs, follow up the outcomes, but it also enables us to monitor much better also the supplier shortages, also delivery chains, if there is any risks due to that, supplier risks in any way. So they bring much more open access also to monitor the whole delivery process than we have used doing. What we have seen in the examples that we have been doing, provider monitoring, there are huge differences in outcomes, in costs, and the impact. It doesn't also always resonate regardless of the costs also. Like I think you said it well, that it's do no less, do no more, and do not harm. To find the fine balance of getting the price point in the right position. This helps us in doing that one.
Thank you, Anna. And Vicky?
Yeah, I think I don't give anything new, but I think that for at least at Aquas and for us, it's key how we can support with digital tools, because at the end we are changing how we are delivering the healthcare in every procurement, right? So even if we have already some metrics established, some tools we are changing that. So this is an opportunity to really create and really be able to monitor how the procurement itself, obviously, but also how the process, when we talk about integrated process, that's key to really know, and for managers, but also for the professionals, right? So it can also be used to facilitate. So if we want to generate these results and we want to analyze them also for patients, for surveys for patients, even for professionals, and obviously, as it was mentioned by Anna, the cost and other results. But there are so much options that you can use and that provide value. And I think that now, as well, with all this data, even we can talk about the use of artificial intelligence in the analytics of those data. So that's another option that, for example, in Radar PPI, they are applying as well for the monitoring. But I think that overall, we need to really facilitate our life in general as we have these tools to really manage the pathway of the patient. That's something that we need at each procurement, so individual, but I also think that also helps for the provider as well, for the industry in a way that it helps at the end, the evaluation and the HTA. And I also think that overall, the value-based procurement also needs to really generate more evidence and continue, because part of the value we are creating is in the evidence we are generating. So really, these tools can help us a lot.
I agree, and I think it's interesting when you look at the history of medicines. You know, we had a system that was critical alerts. You know, the yellow card system. I think it's used when there's adverse events from people being prescribed medications and something happens. And yet, it's only fairly recently that we're getting into the proms and prems. And how many times have we all been prescribed something from a clinician and it hasn't worked, and they've changed the medication or adjusted the dose and all that sort of thing? Do we capture that? Do we look at that in terms of what's effective and what's not effective for different people? Because we're all individuals within scheme of medicines. So
and Leo, this is going to become more important. You know, as we move forward, every disease is becoming a rare disease. You know,
Absolutely.
this is becoming increasingly.
And people are living with so much comorbidity these days. So I think really interesting point. I'm going to skip question 4, panelists, because I think a lot of the answers to that you've covered, and jump to question 5, and because I think this is very relevant. And it's around what incentives we think could encourage industry and healthcare systems to co-create sustainable procurement models and balance the public and private interests. And I'm going to come to you first, Patrizio.
Yeah, so maybe we repeat something that we have already said before, but it's very important to motivate companies, manufacturers, to find Europe an attractive place to come and stay, and also to produce. I'm not saying just doing research, because the market for research is even more difficult to stimulate. We do already some research in Europe, and there are shared research initiatives like the one funded by the European Commission, that are really important for also for private stakeholders to jump in, collaborate, and find a coherent solution. But the industrial policy is a little bit lacking, and it's really not very well coordinated across Europe. And my impression is that if we don't coordinate the industrial policy, it will be difficult really to attract stable manufacturing and not just selling. Because selling is easy, so these are medicines, everybody needs medicines, so there will always be a market for selling medicines. But it's very difficult to keep a market where medicines are also produced. And so, for example, we have historic exporters like Italy, historically is an exporter of medicines with a lot of production. But it suffers a lot the competition from the Far East, because when they are purchased, the prices of having truthful rights for laborers, quality checks, so all this comes with a cost, at a cost, and this cost is reflected in the prices. And also, it should be understood that the growing costs for input for these companies matter also a lot. We have rising costs of raw materials, we have rising costs of personnel, we have rising costs of services, and prices can't be the same. Otherwise, companies will prefer other markets to produce and sell. And again, who will sell in our countries? Foreign competitors. So I think that the most important incentives are the industrial incentives. Providing industrial platforms, ensuring access to the market with tenders that do not only reward the price, but also the fact that they were internally manufactured. I know it's maybe an implicit form of protectionism, so you don't impose trade fairs, but you value the fact that the medicines were produced in the internal market. I think it's a way of being fair in the competition that we have nowadays, also on the prices of medicine with the problem in the US, as you know. We have to protect the internal market. But for this, we must stimulate the willingness to pay of public procurement, assigning different budgets, because that's the reality. If we want to have an industrial market for companies, with companies producing medicines in Europe, we must pay them more, even old medicines.
Thank you. And David?
I think one thing that we're very conscious of. We spend a lot of time looking at innovative medicines, and a lot of those medicines are not simply pills. They're far more. They're actually complex service models, and which require local presence, and so that's a sort of important part of the delivery of those medicines. I think. I keep coming back to price. There has to be sort of confidence that manufacturers can achieve a pricing point that is not going to cannibalize earnings in other parts of the world. That's so fundamental. And whatever we need to do to innovate in terms of contracting or thinking about medicines as an investment is an important part of that. But I think right at the core of all of this is just trust between health systems and manufacturers, and the shift from a 20th century adversarial bargaining model to genuine 21st century innovation partnership. And I think if manufacturers see that, and they see that path towards launch pricing that is sustainable, then access to those medicines, particularly innovative medicines, by default give rise to local services and production.
Thank you. And Anna, final thoughts on this question?
To what I see it is that there is possibility to create the win-win-win situations to all parties. But to get this one, it requires, as you said, we need the demand and we need the operational environment that supports innovation, that kind of creates an operational environment where affordability, but also long-term sustainability and resilience can be combined in the targets that the whole system is aiming at. But it requires exactly to focus on the demand part as well. And there is different risk-sharing models. There is science that we can already bring into the table that have been successful and jointly created with the suppliers and the providers. So we have already tools available also to do this.
Okay, thank you. And the last question that we just have 2 responders to, and keep it really short so that we can sum up, please. Both of you, David and Patrizio, have touched on this, but just if there's anything in addition to what you said already, in response to what steps do you think that the EU and member states should be taking to make procurement a core enabler of health system innovation and competitiveness, and why should they care about manufacturers' worries over US pricing pressure?
Yeah, I'll start very short. So I have written here 3 points. So first, adopt harmonized multi-criteria procurement frameworks that are consistent across European countries. Not identical, but consistent, okay, because every country has different issues there. Second, invest in data infrastructures to monitor also the performance of suppliers, and also share data about potential shortages or opportunistic behavior. So we need partners to be real partners. So sharing is both sides. And third, create good conditions for industrial investment, as we said right now. And I stop here, maybe David can elaborate more.
David?
Yeah, I mean, I think this is as much cultural as it is technical, to be perfectly honest. And we're talking about bringing healthcare into the 21st century. We're not talking about putting somebody on Mars. It's actually bringing things to a point. This isn't hugely complicated stuff. I think, you know, data is at the heart of all of this, being able to collect high quality data, which includes the full patient journey, so that we have a much more complete understanding of the value that medicines are actually delivering. But pricing, I think, is the cornerstone. Seeing medicines as an investment. You know, in the UK, we're all expected to work longer, but brain health is still seen as a cost rather than as an investment in enabling us to do that. So I think cultural as well as technical, and the US pricing piece, I think, is really key here.
Thank you. So hopefully we'll just wrap up. There's been some insight shared by our wonderful panelists today, and we've generated a bit of a discussion on some of the hot topics. And I think, generally speaking, we can all conclude that it's much more than an administrative back office function as procurement. It shapes access, innovation, and resilience. And I think, picking up on a couple of things that have been said, Patrizio said at the beginning, before value-based procurement can start, we need to have the HTA, the health technology assessment evidence, available to us to make sure that we're procuring appropriate products and services. My sort of focus of work for the last 20 years has been on integrated care and how digital can actually enable more integration. And it's really interesting hearing about, I'll put it in the integrated care wording, that we need to focus and move away from a transactional approach to one that is building relationships. That is at the heart of integrating care. It's about people and how they work and communicate together. And then finally, picking up on a comment that somebody made at the end of one of yesterday's sessions, and he was a psychiatrist. We need the therapeutic guidelines to be aligned so that we can link procurement decisions to evidence-based treatment protocols and ensure, coming back to your initial point, David, that the right medicines are available for the right conditions in the right patients. And this psychiatrist sort of indicated that the therapeutic guidelines do not keep up with the procurement of new therapeutics. So food for thought there, and it's all about integrating, isn't it, in the broadest sense. So let's all be great integrators as we go forward. So thank you very much. Let's give our speakers a round of applause.
So we're going to continue the session. Bevan would like to thank
Super
you
job.
for
Yeah,
the
you did a
speakers
great job.
and also for the moderator for this amazing
I could have said everything you said, everything what he said, everything you said. It was like, I was like, oh my God.
You come from the
And given that we work for the same
approach at the breast for connecting data across human, animal, and environmental ecosystems. In this session, we are looking at case studies across Europe, showing how countries are building
Sí, ningún problema.
Our moderator today in this session is Stefano Dalmiani, head of Bureau during Department of Translational Bioinformatics and eHealth Unit in Monasterio Foundation. And the panelists Bruno Gonzalez Uzron, Henrique Primon Cáceres, Ana Laburu, and Paloma Montero Núñez. Stefano is a biomedical engineer and digital health system expert with long career in advancing AI applications, telemedicine platforms, and data-driven clinical research. His work bridges engineering and healthcare to support innovation in precision medicines and integrated and core models. Thank you so much for the speakers and the moderators. And just meanwhile they are coming here, I just would like to say that this is a topic that I have a lot of interest because for my background and also because we joined different systems and also to one proposal. And during these times, like in the COVID examples and other ones, it's very interesting that you see how veterinary data, in the case of zoonosis and other points, means a lot also for human health. And this kind of topics that has been discussed for the past few years are very important to also build up the healthcare in human-based value. So meanwhile they are switching the microphones, I just would like to invite Stefano to the stage, and sooner our speakers will be able also to join in the stage. Thank you so much, Stefano.
Thank you. May I lift the microphone a bit? So waiting for the mic to be ready. We might start talking a bit about the One Health approach that is the centerpiece of this session. I mean, One Health is something that is really complex to address because basically deals with all the aspects around human health, that is the primary subject, of course, but also animal health for the effect, of course. Hi.
Can you start?
Please. How is it, please? I was just talking about One Health and just waiting for you. We are just missing Anna. So today we will see few insights of these several aspects that relates with, that relates with One Health, involving our experts. Thank you for joining this session. We will open the session now with a discussion on the importance of these several aspects, selecting few aspects that might be relevant also for the following sessions. Starting from the Bruno Gonzalez Zor that we have here. He's the head of the antimicrobial resistance unit at Complutense University of Madrid, and he will talk us about on how antimicrobial resistance is monitored and managed in human health. Bruno is a leading microbiologist and expert on AMR, and he advises international organisms, including WHO and FAO, and strategies, and his research shaped the EU approach, specifically also Spanish policies for monitoring resistant patterns and preventing zoonotic transmission across species. And then we have Enrique Limón Cáceres over there. Thank you, Enrique. He's the coordinator of the VINCAT program of the Institut Català d'Oncologia. And he will talk us about the surveillance experience and lessons learned from national reporting systems. Eric has an extensive experience in epidemiological surveillance and data integration across hospitals and public health systems. His work in the VINCAT program has strengthened infection control and improved national reporting standards, not only on EMR, but also in healthcare-associated infections. And then we have Anela Laburu. She's the scientific officer in environmental health, coordination unit of the European project Breakout A2 at the Spanish Agency of Medicine and Medical Device. And she's a veterinarian specializing in One Health and co-leads the environmental and antimicrobial stewardship strategies within European Joint Action on the AMR. That is the Breakout A2 program. She contributes also to Spanish National Action Plan on AMR and participated also in the European WISH program on wastewater-based surveillance. Her work bridges environmental data, stewardship training, and digital tools to reinforce AMR prevention. Finally, we have also Paloma Moreno-Núñez. She's a professor of health science and specialist in preventive medicine and public health at UNIR, Hospital Universitario Ramón y Cajal, on how preventive medicine approaches can help detect and contain health outbreaks. Paloma is an expert in preventive medicine and public health innovation, focusing on early detection system, outbreak management, and health promoting strategies. She also collaborates in research initiatives linking public health data to digital tools that enhance real-time response and coordination. Join me in welcoming our speakers. So coming back to the initial introduction, started just waiting for the speakers to be ready. So today we will move from the theoretical aspects of the One Health approach to something more practical, exploring real example brought by our speakers from across Europe on how the One Health approach can be implemented through national and regional programs. Ultimately, the goal is to understand how the collaboration across disciplines and sectors can translate into one coordinated, hopefully, response at the regional level, national level, at European level. Protecting not only citizens, of course, but also the ecosystem, because One Health is comprehensive, considering the sustainability of our healthcare system. So with that, I would like to open the discussion, addressing a few questions initially to our speakers, starting from Bruno. Bruno, can you tell us how can the One Health approach help Europe accelerate progress against antimicrobial resistance? And second, it was too easy, just one. And what lessons have emerged from Spanish and international EMR surveillance programs?
Okay, so
let's start from the first.
Thanks a lot for the invitation, and it's a pleasure to be here in this wonderful space, as we all realize. So it's very important to get to know what is antimicrobial resistance. It's the most important health problem that we have currently in the world. It's not a personal opinion. The United Nations and everyone agrees that it's the most important threat, so that's important to take into account. And then the One Health approach is to realize that the health of humans does not depend only on the health of humans, but does also depend on the health of the environment and on the health of animals. So they are all interconnected, and not only in infectious diseases that we are going to say today, but also on non-communicable diseases, contamination, etc. So a classical example, or many examples, is you're in the hospital treating patients with lung diseases, and you treat them all the time, but you live in a very contaminated city. So probably the solution is to decontaminate the city and not just to treat the patients, for example. And the classical other example on infectious diseases is rabies. To get rid of rabies, you don't have to treat patients in the hospital at all. What you have to go is to go outside, vaccinate the dogs, and that's it. So this is how we realize that, in fact, the health of humans is not only human-centric, but it's also related to the health of the environment and to the health of animals. So in the field of antimicrobial resistance, we use antibiotics in humans, we use antibiotics in animals, and all these antibiotics and bacteria flow actively to the environment. So that means that antimicrobial resistance is mainly generated in the human sector, in treated patients, in treated animals in the animal sector, and then all this flows in the environment. So that means that we have to, if we want to understand the two main levels of antimicrobial resistance, we have to focus on all these three areas. First, one of them is the emergence. The emergence of antimicrobial resistance can then be in any of these three sectors. And the other is the transmission. And the transmission is also within one of these sectors, not always between sectors, but sometimes within a sector, and sometimes also between the sectors. So that means that the information that we have to gather is not enough if we gather the information on resistance in a hospital, or only in animals, or only in the environment, but we have to understand the flow of all these bacteria and ecosystems, between all these ecosystems. So for that, what we need really is a super integrated surveillance system in Europe. And the world in general. So in the WHO, we are trying. So we have a GLASS program where we have surveillance of different antimicrobial resistance bacteria in the world. So for now, we have 44 countries that help us. But in Europe, we have to acknowledge that it's probably the place in the world where we manage best antimicrobial resistance. So it's really a best case scenario, which is not always the case in everything that we do in the world. But in antimicrobial resistance, yes, we were the first ones that realized that antimicrobial resistance is a threat. We forbid the use of antibiotics as growth promoters in animals already in 2006, where the US did it in 2017. And we embraced the One Health philosophy, so working together, humans, animals, and the environment a bit later, already like 10 or 15 years ago. So this is a best case scenario where we are. And still, we don't have coordinated and data on antimicrobial resistance. And that is probably the most important challenge that we have, that we gather the same results from the different sectors and that they become harmonized. If you are familiar with maps of antimicrobial resistance that we do in the world currently, and in Europe, you see that maps where you see, resistance in animals is going up, and resistance in humans is going down, and antimicrobial use in animals is going up and down. All these data are completely different one to the other. We see the maps, and we are very happy with our maps because we like maps, and they are colored, and then you see, it's green here, and whatever. But the fact is that the human data are only data on ill patients. So we have no data of human people, of healthy humans. All the data that we have for animals, all the data that we have, 100 from them are from healthy animals because it's indicator bacteria that we're getting from animals. So we are comparing pears with apples for the last 20 years and happy with our maps. And from the environment, we nearly don't have anything. So there's a lot of things to do still to try to harmonize in this place. There's at least the data that we are gathering for many years. The good thing of other countries, and with this I finish, and I advise many countries where they are starting with this new surveillance system, Latin America, Africa, etc., is that by knowing the gaps that we have already for 20 years, we are starting surveillance systems that are really integrated from the moment zero. So in places where they have no surveillance system, we are starting to make really integrated surveillance system. And we are doing them in Costa Rica, in Ghana, in some places where they start and they say, how should we start? Don't start like us, by convenience. Yes, let's take the data that you have in the hospital and we'll put them here in a shaker. No, if you are starting with a new surveillance system, let's start properly. And this is what we are also trying to do to our different countries in the world, because also we depend on them, people travel, etc. So we are having difficulties in correcting our integrated system, but we are constructing good new systems because we have learned from these mistakes in the past.
Yeah, mentioning something said by David in the previous session, we are designing system like that and we need to access like that. Mm-hmm. So it's a radical change of approach sometimes. So, okay, we will enter into a further discussion about that perhaps in the next questions. And now I would like to ask to Enrique, from your experience leading the VINCAT program, how can integrated surveillance data across hospitals and regions improve infection control and support the One Health coordination in practice, according to your experience?
Thank you, the organization, for inviting me to explain the experience in Catalonia. To stay here with this panel is incredible Spanish panel. And thank you, Stefano, because you coordinate two really a very incredible moderator with the table. And my apologies to the audience because my English is limited, but I write my response. The VINCAT program is the surveillance healthcare associated infection in Catalonia. We have 72 hospitals and 92 long-term care facilities, and it's about 8 million people in Spain. When we collect data in the hospitals, we collect data in the same way in many hospitals, and this is a little picture, no, but we don't have many separate reports. We integrate reports and we can see trends, not only individual cases, not only the hospital's cases. For example, in many hospitals reports, the same infection, the surgical site infection, we don't have only a local problem, we have a bigger problem in all hospitals around Catalonia. We can investigate together and we have a guidance to all hospitals in Catalonia. In One Health perspective, we connect human, animal and environment data, and we can detect risk early about all the community in Catalonia. And this helps us to solve problems.
I mean, you are managing anyway many hospitals.
It's many hospitals.
And Catalonia is let me say, somehow a lucky place compared to other regions in Europe because you are cohesive, compact, and pretty IT advanced, at least as far as I know, because I work with them in several European projects, of course, based on IT. Thank you, Enrique. I would like to ask Anne instead. How can initiatives just like the European GEMRI 2 and the European WISH contribute to building a more complete and data-driven One Health response across Europe? I mean, we can start from the consideration from Bruno, but
yeah,
it's
exactly.
a different experience.
Exactly. Thank you very much for your question. Thank you to the organizers for having me here as well. And yeah, I think it was a very educational first introduction that we had from Bruno, drafting all the situation with the human health, veterinary and environmental health. So you mentioned that it is the most important health concern at the moment. It is a really emerging concern. Actually, we have this European plan from 2017. Then in 2022, the European Union declared it among the 3 top health concerns for our region. And 1 year later, the Council published the recommendations on stepping up action against AMR in the European Union. So you can imagine that this is really an emerging topic, and we have a political commitment coming. So this has led to the funding of many different initiatives, such as EU WIS or EU Jambrai. We have had 50 million euros. I thought it was a lot, but yesterday the pharmaceutical industry was talking in billions, so I was like, so but it is a lot. It is an unprecedented funding that we are receiving these days. So we are having this money, and we now need to figure out how to really use it effectively. And then this gives us the opportunity to gather many people on the table. So we are having stakeholders from human science, and then veterinary sciences and environmental sciences. We are also involving representatives from authorities, from the pharmaceutical industry as well, from professional authorities. Even patients are involved in our initiative. So we are trying to engage everyone in the conversation. And well, going back to your question, how are we specifically going to address, and how are we going to provide more like a grid, or how are we going to build this consensus about the topic, around the topic? So we are allowing the exchange of knowledge and different perspectives among these stakeholders, and what we are trying to do is have a common framework for the European Union, so we can agree on some very basic points, and then the member states will be the ones translating this into the national action plans. So this is our final aim. The ultimate aim is to translate all this knowledge and frameworks, the common frameworks, into the national action plans. And we will also create, because implementation is very difficult, you know, and yesterday we were also discussing how difficult it is to take the top-down strategies that I mentioned, such as the Council recommendation, put it on the ground. So we are trying to give the member states some tools, provide them with tools, so they can really implement these common frameworks that we are going to be developing during these years. And then, well, in summary, we are going to be responding to this high or top-down strategy thanks to the funding and in an harmonized way. And we are going also to be supporting these bottom-up strategies coming from the experience that countries have, and countries are going to be providing with their real needs. So we are doing something useful and effective, and that can really be used by the stakeholders.
Specifically, if you address and also regional and national capabilities
exactly.
and needs that we know might be really specific, that's a good thing. I mean, it's perhaps the only way to address properly this kind of... Okay, so thank you, Anne. And now for Paloma. How can preventive medicine strategies and digital tools can be combined to promote behavior change and raise public awareness around One Health and infection prevention?
Okay, thank you very much, Stefano, for your work and for your question. Thank you too to the audience joining us today, and thank you to my colleagues for their contributions. Nowadays, investment in antimicrobial resistance, or AMR, is currently focused on technological and biomedical solutions. This bias can be concerning because although AMR is a biological phenomenon, the conditions that enable the emergence and spread of resistance are shaped by political, economic, and behavioral factors. For example, how we use antimicrobials or how we consistently follow hygiene measures. And for this very reason, AMR would benefit from a social approach. However, a strongly biologicist approach continues to dominate the field, especially when we examine where time, funding, like Anne says, and intellectual effort are being directed. The main areas receiving funding include the development of new antimicrobials and the expansion of rapid diagnostic tests. The limitations of this approach may not be evident, but they deserve careful consideration. New antimicrobial agents can never be the sole solution. Resistance begins to develop from the moment a new drug is first used. Similarly, rapid diagnostic tests provide only a partial answer. Their clear benefits can easily be undermined by systemic barriers. For example, in health systems where patients must pay out of pocket, it is difficult to expect individuals to choose a 20 € rapid test to distinguish between viral and bacterial pharyngitis, when a 5 € empirical antibiotic is the cheaper and often faster option for him. This technological bias is mirrored by a notable lack of investment in strategies aimed at behavioral change. Behavioral interventions do not yield results in the short term, so the potential added value of behavioral research in public health responses is often overlooked. This reflects the well-known prevention paradox. The benefits of preventive action are often invisible, for instance, not acquiring an infection, and consequently undervalued in comparison with tools with more tangible results. In this context, those of us working in preventive medicine have long been familiar with the prevention paradox and with the challenge of promoting behavioral change among professionals and the general population. In the preventive medicine department at Ramon y Cajal University Hospital, where I work, we have sought to place digital tools and technological advances at the service of this goal. In recent years, we have developed several digital tools designed to support behavioral change and enhance awareness among both citizens and healthcare professionals. First, we created a dashboard for the surveillance of multi-drug resistant organisms, which provides automated reports for clinical services. These reports, being automatic, can be delivered at the precise moment when professionals are more receptive to addressing the problem. Second, we developed Quick Vaccine, a web application aimed at general adult population, where users can check which vaccines they should receive based on their demographic and clinical profile. And third, we launched the No Hacer app, presented in a game-like format. The app allows healthcare professionals to test their knowledge about do not do recommendations, which are those clinical practices that remain common despite evidence showing they are unnecessary. Antimicrobial resistance, in summary, we will not achieve effective and sustainable progress against antimicrobial resistance if we overlook the social tools required to change behavior. To avoid merely buying time, we need a renewed perspective, one that fully integrates social, behavioral, and structural approaches into our response to AMR. Thank you.
Thank you, Pablo.
Can I say something? Yes, yes. I fully agree. Behaviors, yes, we are very much focused on new antibiotics, and this is not the solution. When you talk about behavioral change, I also agree, because it's the behavior of the prescriber that has to prescribe differently, but also of the society that you didn't mention so much. The behavior of the society is very important, especially in this country. I didn't talk about this country, but in this country, we like automedication. You know, you buy an antibiotic, you have it a couple of days. When you feel better, you forgot what the doctor or the vet told you to finish to have it 7 days or whatever. So you finish like on the third and the fourth day, and then you still have a lot of pills, and then you keep them in your. So we are the first automedicators in Europe. So this is a behavioral thing. This is an anthropologic thing. Why do Spanish people not do what they have to do, that is finishing their course, and why don't they give the antibiotic back to the pharmacy where it has to be destroyed? So there we are working, and we are working physically with anthropologists, behavioral scientists, psychologists, to see how we can change behavior, because until we don't change the behavior, the attitude of the Spanish people, let's say also Europeans, because Italians are worse, until we don't have the behavior of the society against antibiotics, that people think that antibiotic has nothing to do with an ibuprofen or paracetamol, that it's really a last resort drug that we should use as less as possible, we will not achieve anything. And so that's why behavioral change is so much. This is why I said that my logo this year that I invented a couple of weeks ago was, be happy if you don't get an antibiotic. Because when a Spanish guy or an Italian guy goes to the doctor and he comes out without an antibiotic, he's angry. He says, well, you know, it didn't give me an antibiotic. He doesn't even think I'm ill, whatever. In the vet, it's the same. You go with their dog with diarrhea, and he has diarrhea, and you go out and you don't get an antibiotic, you are mad. So we have to change the attitude and be happy, because getting an antibiotic is not the solution. You are disturbing your microbiota. You are creating antibiotic-resistant bacteria in your gut. You are spreading the antibiotic-resistant bacteria in your family and and spreading them also to your dog, companion animals, and you're spreading it also to the environment, etc. So it's much better not to get an antibiotic than to get it. And that's a mindset difference that we have to achieve, and that's thanks to this behavioral change that is really crucial.
Yeah, I think we can cover that in our last question. Yes, Bruno already did, and that's very nice.
Sorry,
I mean, because I subscribe everything that you said, and it's very important that you point out the fact that the environment is there, because people, I think, at least in Spain, think that if you are not taking the antibiotic, you are not going to be developing resistance. But that's not real. We have the environment, which is acting as this place where all these resistance determinants are disseminating and emerging. So even if you didn't take any antibiotics in your life, you can have AMR. So yeah, thank you, Bruno, for also being so educational and introducing this concept that we think everybody knows, but it's not true. So thanks.
Yeah, perhaps we don't have the magic wand to, let me say, support the patient and okay, we will talk about this later. We are wasting so much time in the preliminary question, because this is a set of questions to prepare the field for the real panel discussion. And I will start from Bruno.
But I talk too much. Let's let others.
Because we are talking about cooperation in the beginning. So how can member states really strengthen collaboration between the three aspects, human, veterinary, environmental sector, to build the real One Health response? Not a bunch of early warning systems. We have 81 of them, early warning, not integrated with all the system that has a source of data. So might be also a single response, perhaps useful for one single aspect. But what about building something comprehensive?
I will be very brief. I think that we have to switch from cooperation to co-responsibility. And we are not there. So we are cooperating, sharing our data, but the fact is that the resistant bacteria that are created in one of our countries and in other countries and in other hospitals, and we have that in Spain. In Spain, we import antibiotic resistance. And one of the countries where the future of antibiotic resistance is going to be worse in Europe is Spain. Why? Because we import elderly people from Europe that come for their pension to our coast. All these elderly people have, when they were healthy, they were stayed in their country, but now they come with their comorbidities to our country. So our hospitals, we expect that we will use more last resort antibiotics in our country than in any other country in Europe. So that's why we need this co-responsibility, because all this problem that is generated through traveling from one place to the other will concentrate in our country. So we need really this common strategies, because all these bacteria will finish in our hospitals and in our elderly homes. So we really have to really feel co-responsible of creating and being responsible of all the bacteria that we are creating. Maybe in the north of Europe we have less resistant bacteria, but in other places of Europe we really have to think that what you are doing is also affecting other countries.
I'm going to use that explanation in my hospital when they ask me about carbapenem resistance.
Yeah, well, I think we are lacking some collaboration, and I'd say it's a lack of awareness sometimes. We are very familiar with the topic. We are coming from this healthcare background, and but people are working on their stuff in their boxes. So I think sometimes it's a matter of telling them, okay, we have this issue, it's a big one. We really need to work on this. And yeah, putting this in the back of their heads, it's the first step, so they can be willing to collaborate. Then I think sometimes, well, our message has to be very, like, highlight the severity, but sometimes we can go too dramatic, and it gives the feeling that we have nothing to do, it's too late. So we should try to avoid that kind of messages and tell them, like, okay, there is a solution if we work together. And then there is another thing I think we should be avoiding, and it's doing like this blaming game. When we want to engage some stakeholders, we usually go to them and say, okay, we have this problem, and you are part of it, and you are contributing to it. So this doesn't work. Imagine you are at home with your partner, and you say, this house is a mess because you are so messy. Don't try this at home. I mean, this will not work. You are not going to make him or her want to collaborate. Maybe you can have a conflict, or they will ignore you. So I think it's very important to have like this kind of very positive message and engaging message. And that it is like you are part of the solution, and we need you to get to a solution together. And this goes in line with what Bruno said about responsibility. This is the way to make them feel responsible for something and have this willingness and proactivity to work together. And then I think collaborating is like, it takes an extra effort, because we all prefer to be working on our things under our language that we can easily understand. Last week I was in a meeting, I was invited to talk in a meeting with different people, but most of them were chemical engineers, and I was there struggling a lot. So I wish I was with some colleagues talking the same language as I do. But then there is a sentence that I really like, and you may know. It's, if you go alone, you will go fast. If you go together, you will go far. So you need to insist on this message. It is a challenge to collaborate. It's difficult, but I think it is worth it. And then once the awareness is there, I think we need to work on the capacities and start the training. So this is what we are doing at EU Jamrai. Training is transversal to many of our work packages, and especially in the task that I lead, we are working on a pilot program for capacity building. And we have this mandate to be very innovative. So we have developed a tool, a digital tool that you might have seen on the screens these days. So this is a tool for anyone who's interested in developing a capacity building program. And it is a facilitator to choose the best method depending on the target audience that you want to approach. And then you can also enter, it's like a filtering system where you can put different criteria such as cost considerations, time demands, or even the learning modality, for example, if you want to learn by doing or by seeing, and the tool is going to suggest you the best methodology depending on those criteria. So, and then you have this step-by-step implementation guide. And I think I want to insist in this kind of tools, because we are talking sometimes too superficially, but you need to put it on the ground and develop it. And the know-how is very important. So these kind of tools are really important to help different interventors develop their own interventions.
I agree that awareness is crucial.
Yep.
And let me say that also in my hospitals, when a physician collects data in an EMR system or EHR system, I'm not really aware that it's just compiling one piece of the whole information that needs to be related with the patients and with the pets of the patient and everything else. So this is something that perhaps needs to be supported more, and perhaps we might have some solution. I don't know, Enrique, what do you think about that?
I think first we need establishing interministerial committees. We, in Spain, the PRAN team changed the perspective about all the country. No? We need One Health task force, can ensure regular dialogue and share decision-making about relevant authorities. Second, developing interoperable digital platforms. I think this is very important. And platforms real-time data exchange between public health, veterinary service, and environmental agencies. Third, investing in cross-sectoral training and capacity building helps professionals understand interdependencies and adopt common protocols. And four, launching pilot programs. And finally, aligning national strategies with European initiatives, JAMRAI 2, and dedicated funding for joint actions.
So we might have a solution, at least for Spain. But let me say that Spain is really similar to many other countries. Yeah. Because the local government might say something that is really the opposite of the European trends somehow. And this is also related with the technologies. And I would start from you, Enrique, asking what are the main barriers for you to sustainable data sharing between the different competent stakeholders? We are talking about internal hospital allocation, inpatient, whatever laboratories that might be involved in the One Health approach, really something that might be around the human health and animal health and environment. How we can break these silos that we continue to have right now?
Maybe Bruno say the spoiler about this question, but for me there are two main barriers, technical and cultural. Technically, systems are different and do not connect well with both, and culturally, people worry about privacy, ownership, and reputation. To solve this, we need rules from governments to protect data and explain how to share. We need small joint projects like testing water together, help build that trust. When people see real benefits, they are more open to share data.
Yeah, sure. And we are coming back to the behavior of problem. We need to look at the people behavior. Why a single citizen, healthy citizen also, wants to donate somehow his or her data to something that he or she doesn't really understand why, and doesn't have also back something, not as a reward, but just as a result from the research, from the many initiatives that we are currently managing at European, national, and regional level. So we are lacking of this kind of feedback out of the, let me say, involved stakeholders, patient association, scientific association that are directly involved in such programs might see what is happening, but we don't have it for the general population that level. Anne, what do you think about that?
Well, I was going to say that it's a problem here in Spain, but I know it's a common problem that we have in all the European countries, the fragmentation of competencies. We have different ministries and authorities for topics that are very diverse, but have a lot of synergies. And yesterday, there was another sentence that they said, we have a big diversity, but we should try to find synergies. So working on those synergies, we can try to overcome the challenge of this fragmentation of competencies. And for example, I'm working in environmental approaches, and just to illustrate you with a practical example, let's say, we have the Ministry of Health, for example, doing the surveillance of an antibiotic in drinking water, but then we have the Ministry for the Environment doing the surveillance of the same substance in surface waters. And then we have these separate databases, and if we want to analyze all the data from the AMR perspective, we need to go and dive in different data sets, and it's so complex. And so we are trying to overcome that. For example, in the EU JAMRAI, we have this work package which is working, we are doing this study of how to integrate the different data sets and different surveillance systems that we have in humans, animals, and the environment. And we want to come up with a solution so we can have a One Health report and then have a dashboard, a common dashboard. So we don't have this fragmentation of the information, and then we can better inform decision making as well.
Thank you. That might be good approach.
Yeah, a difficult one.
Yeah, but okay, we will talk about this perhaps later, but you know all that exists now, the European Health Data Space is perhaps the right container for all the information that we want to collect across all the different domains in order to build the One Health strategies and solution on that. This is something that is not expressively mentioned in the EHDS. Might be reading between the lines that exists one solution that collects all the information from all the fields, but the environmental, for example, data is something that is somehow neglected because it's not personal. It might be easier for the application of GDPR, of course, and sometimes it's something that might be further investigated in the next future. And okay, so we might ask also comments from Bruno.
Yes, well, the problem that I've encountered with One Health is not only digital sharing and platforms, is that people don't understand that we are working too much in silos. So finally you end up with a silo of the digital data of one, and we are patching and trying to put this together. I think that what we are lacking in Europe is One Health structures. And we don't have One Health structures. We have a task force that tries to coordinate, whatever. And they send emails from one to the other, and sometimes they meet. But to really operationalize One Health, you must physically, and I mean physically, sit together, look into each other's eyes, spend the time, and only then you understand, these people that are working on the wastewater treatment plants, it's true, it takes hours to explain them what is a bacterium because they work normally with other pollutants, but then suddenly they say, now we can help. And this comes when you physically make structures where people physically meet. I think that's really essential. Because I've seen it, and I've seen it. You send an email from the Ministry of Agriculture to the Ministry of Health. You have a week to answer, and this is how the task force are working in most of even in Europe. And this is not how it works. You must really make One Health structures where you have common governance, common budget, common solutions, common people, and then it's the only way where this really takes off. And we have seen this, and I've not answered to your first question, in a national action plan in Spain on antibiotic resistance that only started 10 years ago. So when it started, I said, look, I'm working for 20 years in the national action plan in the Netherlands, in Denmark, so this is too late. But the advantage of starting late is that we started from a One Health perspective. So we started in the National Medical Agency. And the National Medical Agency works with medicines from humans, medicines from animals, and residues in the environment. So it's a One Health national action plan. So it started to be, the Spanish people start late, but now it's an example worldwide because it's a really One Health national action plan where the people work together on the environment. And this physical thing is crucial because when we go to the meetings, and you go to the meetings because I also work with them, people talk to each other, and they know perfectly that when you talk about a cow, that it's equally respectable that if you talk with of a patient in an intensive care unit or of a guy that has never heard about antibiotics who is working in wastewater. And this physical cooperation is essential. And this is what we have achieved, I think, in the National Action Plan in Spain.
So it might be solved at coordination level at least. Coordination, of course, at political level. That might be
the structure, the physical structures, I insist.
Yeah. But let me say that in Italy we adopted the One Health approach in 2016, so we are also later than you, but don't worry about that. So Paloma, what is your thought about?
I'm going to talk from a hospital perspective, but we have very similar problems. I think it's one problem manifesting in different areas. In hospitals, health data used for surveillance come from many different sources: microbiology, pharmacy, electronic prescribing, electronic patient records, and even natural language clinical notes. These data differ in format, scope, and content. Some are highly structured, while some others are completely unstructured. This diversity is not a problem itself, as this variety should enrich our understanding of health problems, but the real issue here is that we lack harmonization. We do have international standards to solve this. SNOMED CT for clinical concepts, LOINC for laboratory observations, and the International Classification of Diseases, ICD, for diagnosis coding. We even have powerful architectural models like OMOP, and together they could make data sharing much easier. The problem is not the lack of standards, the problem is that their adoption is still limited. A second barrier is that these systems have mainly been designed to facilitate secondary data use by analysts and managers, but not support everyday clinical decision-making. So clinicians rarely see any direct benefit in the daily workflow. And I think that is such a problem in the quality of the data, as you said before. This leads in Spain to another structural weakness, the fragmentation of electronic health record system, and I talk about that. Each region and often each hospital uses its own platform and its own interfaces. As a result, even within the same country, data flow is extremely limited. And unless we move towards a single unified electronic health record accompanied by a fully harmonized system, sustainable data sharing will remain extremely challenging. So what can we do? I think we need a two-level approach. First, a strong national strategy for semantic harmonization, fully implementing these standards, SNOMED, LOIC, ICD, or OMOP. And secondly, we need to redesign interoperability tools so that clinicians, not only IT experts, can actually use and benefit from them. Interoperability programs are mostly used in management and health economics. Maybe if it improved clinical workflows, it would be easier to prioritize them. Regarding a specific solution, I'm afraid I don't have an answer. But I'm sure people in this forum, my colleagues, or even the audience, may know the potential of this system better than me. One thing is clear, interoperability is not a technical luxury, it is a prerequisite for modern public health, for AMR surveillance, and for making One Health a reality.
Thank you, Paloma. Indeed. Yesterday we heard about Fulvio Raffaelli talking about European initiatives, try to build something, at least talking about human health. We never mentioned yesterday animal or environment. Currently we are not even mentioning AI, so perhaps later, I don't know. And the semantic standardization might be crucial because the European action right now is on data exchange, because we need to support patient care across the different countries, but many times also within the same countries that are lacking some support, and of course use on behalf of some EHDS secondary pupils the same data for research, but passing through the health data access body that is basically another silos. So also in the new paradigm of data usage, we are building silos. One silos for healthcare and one silos for research. And I don't know if One Health might fit on the other silos, because the environmental data definitely might go into the, let me say, data exchange, but are not data to be anonymized. That is, let me say, the jurisdiction of the health data access body silos. So this is something that might be crucial also to address for the next future. I mean, we are just started with the HDS, so we need some years to understand what will be the next future, implementing techniques for the data exchange, interoperability, essentially. And so thank you, Paloma. I will start from you with the final question, because you are also an expert on that. How can behavioral change and communication strategies, and we are talking about the citizens, but also health professionals, talking about who prescribe the antibiotics, reduce AMR?
Okay. I'd like to focus my answer in communication strategies, because recently I read an article from Bradley Lamford, a Canadian scientific, talking about this subject. The article was titled "Beyond the Echo Chamber, Reframing AMR Awareness Efforts to Reach the Other 99%. Those of us who work in antimicrobial resistance make up less than 0.1% of the population. We warn constantly about the threat of AMR, but who is actually listening to us? When we speak at scientific meetings or conferences, our message reaches people who are already aware of the problem. When communication stays confined to expert circles and academic journals, it becomes trapped in an echo chamber. Langsford team provides some striking data from a national survey on how the Canadian public perceives AMR. Only a quarter of respondents had ever heard of antimicrobial resistance. And once the concept was explained to them, more than half believed there was very little anyone could do to address the problem. Surprisingly, even among healthcare professionals who do understand what AMR is, the attitudes are not much more optimistic. There is a tendency to shift responsibility elsewhere, to other regions, other clinicians, other specialties, or even to patient pressure. This reduces their own sense of agency over antimicrobial use, which we know is one of the main drivers of resistance. And perhaps most importantly, clinicians often feel that other health issues such as obesity, diabetes, or smoking are more urgent than AMR. And Bruno says in his intervention that AMR is a very important subject now, maybe the most one in the future.
No doubt.
So going back to the core question, how do we break out of this echo chamber? We have two possible solutions. First, we need to learn to communicate better. We must become better storytellers, use clear metaphors, and design visual materials that really help people understand the issue. The public deserves accurate information, and it is our responsibility to ensure that the message reaches them in a way that is both accessible and rigorous. We need conversation about antimicrobial resistance to happen not only at expert panels, but also around the dinner table. On the other hand, in hospital settings, patient education is not always the strongest component, but there are major efforts aimed at improving staff training. In Spain, most healthcare centers have antimicrobial stewardship programs led by multidisciplinary teams. These teams do far more than support difficult prescribing decisions or advice on the use of new antibiotics. A significant part of their work is dedicated to training clinicians. This year, for instance, in my own hospital, the PROA team delivered multiple educational sessions to clinical departments, held a hospital-wide seminar, and created short training videos for junior doctors. Even they launched a prescribing audit program. These are concrete strategies that go beyond theory and help change practice. And the second solution, we need to shift the narrative. AMR should not be framed as an unavoidable apocalypse. It is a serious problem, but it is also one we can address. Our communication must motivate action, not generate paralysis through fear. If we want society to engage with AMR, we have to meet people where they are. We have to step outside the professional bubble and invest in communication that resonates beyond the scientific community. Unless we bring society into this conversation, we will be fighting this battle with only a fraction of our potential allies.
Thank you, Paloma. I mean, this is really scary to know that just 50% of people knows about that. And it comes to my mind, my mother, because a couple of weeks ago, she took a couple of pills left over from the previous prescription, just because. And this is a big problem. But perhaps this problem might be mediated by different actors. I don't know, working at the provision level, working with some ads campaign at pharmacy levels, not only at prescription, because once that you have some leftover, Bruno just mentioned the proper usage.
And I wanted to include an actor that we have not mentioned, and that is education at universities. So in Europe, we are starting to work not anymore in single universities, but in universities network. And by the European research area, we're working in networks. So I'm the president of one of them. There's Una Europa, with the University of Bologna, La Sorbonne, Edinburgh, etc. So we're 11 universities, and our main pillar is One Health. And we are seeing really results because in all our universities, we cover from philosophy to medicine to vet medicine. So we cover 500,000 students and all different subjects. And there, by doing summer schools, conferences, etc., really from bottom up, we are really making putting the One Health philosophy in the head of all the professionals of all different areas in most of the countries in Europe. And I think that even if it sounds it's long term, time flies. So when we started 6 years ago, and the students there are already professionals working. So I think that university clean and academic strategy will also help a lot, because it's not something that you learn. As I said, it's something that physically you have to be confronted to. And if you are in the university studies, I think that also helps.
Yeah. I want to endorse this, and we are also working on this line in the EU Right. We are creating this network of educators, because we think that we should be including this topic in the curricula of different people that are going to be the professionals of the future. So yes, not only for those focused on health, but also maybe for those focused on social sciences or economic sciences as well.
Communication.
Communication, exactly.
Currently, One Health, I know that is one course, but for just one specialization of medicine. So extending the range of the One Health approach to basically everybody, because when you start providing some medication, you need to know what you are providing. Just like you have some from the surveillance system, some signals from the interaction between drugs or changes of something, we should perhaps embed this in some surveillance system directed to physicians or prescribers at least, that make them aware that they need to at least monitor the administration. And this is perhaps one of the crucial aspects that is involved in communication strategies, because the patients, because once that you are taking a medication, you become a patient. Are somehow controlling the administration, many times using also some caregivers, family caregivers, informal caregivers also, so also the education of caregivers might be crucial. But we are talking about millions and millions of people, so how can we address millions and millions of people? So without a single aspect that can support the communication for the broader amount of population. So we need to find a message for them that says, okay, be aware that the next time that you take that medication won't be so effective, because be aware of that. And this is something that perhaps might be vehiculated from the prescribers and from, I don't know, in the hospital we have some control environment, because it's really strictly audited with the prescription and administration of antibiotics. But elsewhere we have the same effect of, okay, leftover medication is worth medication anyway.
But be positive, don't be so negative, be positive, because we have been able to reach education and behavioral change in Europe. Incredibly. I can give you the examples in Spain, where we started to talk about non-smoking in bars, and in this, it was, everybody said this is not going to happen. In the bars, you smoke with your friends, it's impossible. And in a very short period of time, through good communication, 100% of the society is convinced that this is what we have to do. And is happy, it would never go back. So the behavioral change, even if it's millions of people, as you say, is not impossible. If the message is properly done, if it's well communicated, etc. We have reduced car accidents in Spain by 5 times. By 5 times. It's impossible to, as Spanish people, it's impossible to let them not drink when they take the car, or to put the safety belt, and we reduced it, through a proper campaign, maybe also through some punishment by the police. So a mix of strategies help to reduce factors. So I think we can reduce antimicrobial resistance, and we can reduce the attitude towards antibiotics, even if it's millions of people, but the right message, the right people, and the political will. Because when we are financing our campaigns against antibiotic resistance in Spain, we have money to make a campaign for 2 days during the a week of antibiotic resistance, that is the week of the 18th November, and that's it. But in France, for example, they took it seriously a couple of years ago. Les antibiotiques, c'est pas automatique. And that was on TV for weeks and weeks and weeks, and the next year again, and the next year again, and that's how they reduce. So yes, you can, but you need this political will to do that.
Please, Enrique.
No, I think is the time to connect the communication about the human, animal, and environmental health message. I think this is more important in this time now. Because, for example, coordinating campaigns between antibiotic use in livestock, environmental contamination, and human resistance. I think this is the link with the AMR campaigns.
It's a complex link.
It's complex.
This is just to add on this. This is exactly what we are doing in the EU EMRA. I am not an expert in communication nor in behavioral changes, but we have this structure where we have, for example, a work package working on antimicrobial stewardship, and one of the tasks works specifically on behavioral change. So we are doing, for example, guidelines for the rational prescribing and use of antibiotics. Then we have this other work package working on infection prevention and control, and we also have this team working on behavioral change, so we can improve this IPC system through vaccination or hand hygiene or disinfection, whatever. So we are really working with the behavioral change of professionals. This is like the practice item that we have. We have knowledge that we mentioned, and we need to address with training. Then we have practice and attitudes. So this is this pillar of practice. And then when talking about the general public, we are also having this great team of communicators working on this. I invite you to check all the materials that have been launched. We have this very, very great and funny campaign with memes. And we have discovered that the humor is very context specific, so they are really adapted to each country. And then the same for this campaign about illustrations. And we have many different fun illustrations on the topic, so I also invite you to check those. So yeah, we are really working on that. And about the environmental approaches specifically, we are trying to incorporate this perspective in those messages. You mentioned the role of the general public managing leftovers, and this is crucial. We are in close collaboration working with SIGRE. SIGRE is the national system for the proper management of disposals and disposal of leftovers. So we are trying to make people aware of having good practices and avoiding, for example, flushing antibiotics down the toilet, which is a practice that it's quite common. It's not that rare. So yeah, we are working on that as well.
Also, waste management is a crucial thing.
Yes, it is.
So I would like to close more or less, but with one final word by each of the panelists. I would ask you to select one keyword to summarize your point of view. Starting from Bruno.
Key sentence.
So
more words. Really more than a word. More than a word. Okay. That I wrote down. That I wrote down. So I think, and I've not talked about this, but so we have to build one unified genomic, one health surveillance system. I talk about genomics because I think it's a common language that we have in antibiotic resistance, and we haven't. So one platform, one early warning mechanisms, and one coordinated response. You're impressed with my. I can be brief when I want. So genomics, coordinated, one health response, unified, common platform, early warning mechanism.
So you can use one of them. Yeah, we didn't touch the genomic aspect because it requires perhaps other 10 sessions. talking about the exposome, talking about the genomics of bacteria. I mean, we don't have the time right now, but Paloma, what is your keyword?
I have to say behavioral change strategies. And World Health Organization have a model. I think Anne knows it because it's very similar to the experience you have talked about, which is called COMBI, about capability, opportunity, and motivation to change behavior. And now they have a document about how to apply COMBI to fight against antimicrobial resistance. So I recommend you to read it. It's almost 100 pages, but it's interesting.
Thank you. Henry?
I have only 3 words.
Okay, less than Bruno anyway.
Inclusive communication, professional empowerment, and systematic supports.
Yeah, these are good keywords. I mean, this is something that really summarizes the communication aspects. And Anna, what is your
I
keyword?
wasn't prepared for this. I don't know if I missed this during the script. But I would say like something like the power of being one or something like this. We have this included in our promotional video. So I think, yeah, we should focus on being one, working together, and this is a powerful message. One, yeah.
Thank you.
One is the word.
Thank you. Thanks to our panelists. Okay, today we have seen some success story somehow, and we have seen how the connection between the human, animal, and environmental aspects are really connecting to the One Health approach. And this includes also some specific domains, just like hospitals, that are currently perhaps one of the topics addressed by several European actions. But by my point of view, perhaps one keyword, also recalling some session from yesterday, is uncomfortable interoperability. Because we are advocating for high-level interoperability, but currently we are not reaching that level because perhaps we are lacking some resource. We spent a lot of research in many different ways, but we still need some research. And we need to change some structure to properly support this kind of interoperability, to support the One Health approach, the real One Health approach. And the other point might be that perhaps the recommendation that right now we have at European level needs to be some regulation, converting to regulation that each country needs to apply. That might be perhaps a big point, but this requires a high level of agreement of data that we need to collect for each specific instance at national level and, of course, at the European level. So, in wrapping up, the One Health is currently no longer an aspirational concept. It's something that is concrete, is here, is an operational necessity, and we need to make it work somehow, because we have to harmonize also our data silos, our way to think about diseases. Paloma mentioned the semantic representation of information that stands behind each data exchange. And this is something that increases the impact in the adoption of the One Care approach. Thank you to our panelists.
Thank you.